Hello everyone. Am I audible, guys, and visible? Guys, can please let me know in the comment section. Am I audible, guys? Yes. Thank you. Thank you. Hello, guys. Okay, we can start. Good evening, everyone. So today we have a high discussion of obstetrics and gynecology. I hope you guys are all revising your obstetrics and gynecology. So for a quick revision, we'll give in a form of a test and discussion. Okay, so I'll be discussing around 30-40 questions, and we'll try to cover up 30-40 questions in 2 hours. And after every question, we'll go for a detailed explanation. Okay, and if you have any doubts in between, you guys can ping me, or you guys can just type in the comment section. I'll be checking your comments as well. Okay. So every single topic, every single question that we'll be discussing and related topic, I'll be explaining as well. Okay, so start with the question number 1, guys. So let's begin with the question number 1. Which of the following is the most probable cause of bleeding per vaginum 24 hours after the delivery? Okay, so the question says that what is the most probable cause after the delivery for which occurs 24 hours after the delivery? Okay, so guys, if we know that bleeding after the delivery is a classical diagnosis of postpartum hemorrhage. What is your diagnosis, guys? Postpartum hemorrhage. Okay, now this postpartum hemorrhage, we exactly know, guys, what is the cause when there is an abnormal conduction of the third stage of the labor. Okay, when there is an abnormal conduction of the third stage of labor. If I discuss about third stage of a labor just a little bit, so that you will get a clear cut that what exactly can be the reason for this postpartum hemorrhage. Okay, I'm getting your answers as D. I can see in the comment section, guys. We will land up in the answer, guys. Okay, I will rule out all the options and you guys will land in the correct answer. Okay, so guys, before discussing this, before directly going to the answer, guys, let's discuss a bit about this postpartum hemorrhage. Okay, now if I talk about this postpartum hemorrhage, guys, I know that it's a complication of a which stage of labor, guys? It's a complication of third stage of the labor. Okay, for example, if there is a sudden contraction of the placenta, okay, delivery bleeding will happen, so that bleeding is called as postpartum hemorrhage. So PPH is an obstetric hemorrhage which occurs after the delivery. Now this PPH has two types. This PPH has two types. Okay, this PPH has two types. One postpartum hemorrhage is primary postpartum hemorrhage. Okay, primary postpartum hemorrhage which occurs within 24 hours of delivery, which occurs within 24 hours of delivery. Okay, and another one is secondary PPH. Another one, my dear students, is secondary postpartum hemorrhage, and this secondary postpartum hemorrhage occurs 24 hours after the delivery. Okay, it occurs 24 hours after the delivery. Okay, if we talk about a simple basic definition of this postpartum hemorrhage, blood loss of 500 ml in the normal vaginal delivery and more than 1000 ml of in case of cesarean section. In case of cesarean section. Now let's go to the causes of this postpartum hemorrhage. If I talk about causes, guys, you all know there are 4 T's. Okay, meanwhile, when I'm discussing these topics, you guys can write in the comment section so that you will be able to recall your knowledge. Okay, so if I talk about causes of postpartum hemorrhage, we have 4 T's. 1 T is stone. Okay, 1 is trauma, 1 is tissue, and last one is thrombin deficiency. Thrombin deficiency. So tone, trauma, tissue, and thrombin deficiency. Okay, what do I mean by tone or atonic uterus, my dear students? Over distension of the uterus. Okay, over distension of the uterus. That means the uterus is large. That means the uterus is large. Over distension of the uterus, large uterus. So what can be the conditions that you can have a large uterus, guys? So it can be polyhydramnios, it can be twin pregnancy, it can be infection like chorioamnionitis, or it can be a macrosomic baby in case of a gestational diabetes mellitus. Okay, so that is a cause of a postpartum hemorrhage. If I talk about trauma, guys, due to the obstructed labor, there can be lacerations, there can be rupture, there can be tear. That goes with the trauma. Okay, guys, lacerations, I will write lacerations or tear. Okay, in tissue, guys, there can be retained beds of placenta. Okay, retained beds. Okay, retained beds, or there can be a thrombin deficiency, von Willebrand disease can be there, or idiopathic thrombocytic purpura can be there. Now the question is, there are two types of PPH. One is primary and another is secondary PPH. If I talk about primary PPH, my dear students, most common cause is atonic uterus. That means atonicity, tone related. Okay, primary PPH, most common cause is atonic uterus. And if I talk about secondary PPH, secondary most common cause is retained tissue. Okay, which tissue, guys? Placental tissue. Okay, retained tissue or placental beds. Retained tissue or placental beds. Now tell me, guys, what can be the answer? What can be the answer? Which of the following is the most probable cause of bleeding per vaginum which occurs 24 hours after the delivery? So what is your diagnosis, guys? Sir, our final diagnosis is what? It is secondary PPH. It's secondary postpartum hemorrhage. It's secondary postpartum hemorrhage. So what can be the most common cause or probable cause for the secondary PPH? Write down in the comment section, guys. What can be the most common cause for secondary PPH? Very good. Exactly. The correct answer is, guys, retained placenta beds. Retained placenta beds. Is it clear, guys? I hope now you land in the correct answer. All those who are saying atonic uterus. Yes, atonic uterus is a cause of which, guys? Which PPH? It's a cause of, it's the most common cause of primary PPH. It's the most common cause of primary PPH. Is it clear? Good. Now if I talk about treatment, guys, of this postpartum hemorrhage, let me discuss a little bit here about the treatment of this postpartum hemorrhage. We first start with the prophylactic drug, guys, oxytocin. Okay, 5 to 10 units you will give, then followed by drug of choice is also oxytocin, guys, 10 to 20 units. And remember that never give IV bolus because it can cause a sudden hypotension. It's a NEET PG recall question, guys. What can be the complication of an oxytocin if given IV bolus? Is it clear, guys? After that, you start with a ergometrine, methyl ergometrine. Okay, you start with the methyl ergometrine. What can be the what can be the question they can ask from the methyl ergometrine, guys? The contraindication of this methyl ergometrine. So what can be the contraindication of this drug? Remember, in a question they will give the patient having a blood pressure more than 140/90. So in a pregnancy, you're diagnosing it as a pregnancy induced hypertension. So remember, in case of PIH, in case of pregnancy induced hypertension, the drug methyl ergometrine is contraindicated. PIH, it is contraindicated. Okay, any congenital heart disease? Any congenital heart disease, or in case of a RH incompatibility? In case of a RH incompatibility, this drug is contraindicated. Then the third drug we will use prostaglandin E1, misoprostol, prostaglandin E1. Followed by that, we can use PGF alpha 2, PGF2 alpha, carboprost. The routine drug, if it's a drug, if resistant to all drugs, your best drug you can use is injectable carboprost. Okay, NEET PG question was again asked that what is the maximum dosage of this drug, carboprost? Okay, what is the maximum dosage of this carboprost, students? So remember, guys, you can give up to 0.25 mg one dose. Okay, and you can maximum give 8 doses. You can maximum give 8 doses, and which goes to mg, which goes to mg. So remember that what is the maximum dose of PGF2 alpha. Followed by that, guys, we can go for the tamponades, balloon tamponades, Buckley's balloon, Foley's catheter. And if not able to stop the bleeding, guys, we go to the surgical management. We go to the surgical management. So what is the surgical management of PPH, guys? What is the surgical management? If I talk about the surgical management, we start with the compression sutures. What are the sutures we go for? We go for Heyman sutures or the Billing sutures. Okay, we can go for co-square sutures. We can go for Gunshall sutures. Remember the names. And then followed by that, remember the order of the arteries that are ligated, starting with the first one, uterine artery, then ovarian artery, then internal iliac artery. Internal iliac artery. But which branch, my dear students? Sir, anterior branch. Okay, if you ligate the posterior branch, what will happen? Posterior goes to the lower limbs, guys. There will be, the patient can complain of the numbness of the lower limb. Okay, patient can complain of the numbness in the lower limb. Still, if not stopped, bleeding is still not stopped, above all, you could directly go with the hysterectomy. You directly go with the hysterectomy as last option. That will be the last option. Is it clear? So it was all about postpartum hemorrhage. It was all about postpartum hemorrhage. Everyone clear, guys? So I hope all PPH we covered in the one slide, guys, and all the possible questions that can be asked. This much is enough. Is it clear? So again, I will be repeating very in a fast view, guys. Postpartum hemorrhage is the bleeding after the delivery. Why this bleeding occurs, guys? It can be the complication of which stage of labor? Third stage of labor. What is third stage of labor? When we deliver of the baby to the delivery of the placenta. Delivery of the baby to the delivery of the placenta. Okay. So what can be the two types of postpartum hemorrhage? Sorry, there is a primary postpartum hemorrhage and there is a secondary postpartum hemorrhage. Primary PPH means when the bleeding occurs within 24 hours. Okay. Secondary postpartum hemorrhage means when the bleeding occurs after 24 hours. When the bleeding occurs after 24 hours. What can be the probable causes of the postpartum hemorrhage? There can be atonicity or the over distension of the uterus. What do I mean by atonicity or the increased tone? There is a over distension of the uterus or the large uterus What can be the conditions we are having the large uterus? So the conditions like polyhydramnios, when the amniotic fluid index exceeds more than 25. Okay, there can be twin pregnancy, there can be a macrosomic baby, more than 4 kg baby in case of a gestational diabetes that we have. Okay, or there can be the infection of the chorion, so chorioamnionitis. In such conditions, there will be a large uterus and it's a probable cause of the postpartum hemorrhage. Then the second thing, guys, trauma, already discussed that there can be laceration due to the obstructive labor, there can be tear, okay, or there can be hematomas. Followed by that, retained bits, sometimes small bits of placenta remain inside, and then the patient will complaining of the bleeding. So that's also the cause of postpartum hemorrhage. And then thrombin deficiency. Okay, that von Willebrand disease or the idiopathic thrombocytic purpura. Okay, so it all goes with the causes. I already discussed the management. We started with the prophylactic drug. Already you have to give, as per the active management of third stage of labor, you have to give this uterotonic agent. So oxytocin you're already giving at that time. How much, my dear students? 5 to 10 units. Followed by that, the drug of choice will be your oxytocin, 10 to 20 units. And never give IV bolus. This is the question, guys. Again the question, guys. Oxytocin, no bolus. It can cause sudden hypertension. It can cause sudden hypertension. Okay, this is again a question. So I have discussed all the questions that can be asked from this chapter. Okay, so I hope it's clear now. And remember the order of the arteries that have been ligated: uterine artery, ovarian artery, and internal iliac artery. Which one? Anterior branch of the internal iliac artery. Never ligate the posterior one. Why? What are the branch of the posterior one, guys? Remember the branch. We have superior gluteal, iliolumbar, and lateral sacral. Okay, they are posterior internal iliac artery. Okay, posterior internal iliac artery. And this is a discussion, guys. I hope you have revised your main notes. Okay, everything will be written over there. So quick recap of this chapter, postpartum hemorrhage. So the question was, what can be the cause after the 24 hours? So secondary PPH, your answer goes with retained placenta bits. Then how do you manage this retained placenta bits, guys? If there are more, you go with the curettage. Okay, and then later on, if due to the curettage there are additions and all, what can be the diagnosis? What can be the complication, guys? Anyone in the comment section? After the curettage, guys, there can be the additions and synecdoche present. So what will be your answer for that? That goes with the Asherman syndrome. That goes with the Asherman syndrome, which is also called uterine synecdoche. Okay, so what will be the treatment for that Asherman syndrome? You go for these additions, you will go the surgery, additionalisis karoge. So that will be the treatment for Asherman syndrome. Chalo, guys. Okay, all clear? Write down in the comment section, guys. Did you understand the question number 1 in a detailed way? This is the most you have to remember for this chapter, and it's more than enough to solve the question from the postpartum hemorrhage. Good. Excellent. Anyone with any single doubt to the related discussion that we have discussed? Any single doubts from the postpartum hemorrhage? Very good, very good, very good. All those people who are answering, excellent. Great. Chalo guys. Yes, sometimes they will write in the rather than mentioning the Asherman syndrome, they will write the another name, uterine synecdoche. Chalo, let's go to the question number second. Okay, yes, this discussion will be very useful. Chalo guys. So second question is like in polycystic ovarian disease, the drug used for hirsutism and acne is. Okay, in polycystic ovarian disease, what is the treatment for hirsutism and acne? So if I talk about the reason of hirsutism and acne in case of a polycystic ovarian disease, what is the reason of this? What is the reason of this hirsutism and acne, my dear students? It is due to the hyperandrogenism. It is due to the hyperandrogenism. Due to hyperandrogenism, there is hirsutism and acne. There is hirsutism and acne. Okay, now let's discuss a little bit polycystic ovarian disease. Let's discuss a bit polycystic ovarian disease. Okay, so guys, if I talk about polycystic ovarian disease, there is a criteria to diagnose. First of all, what is the criteria called? Sir, it's called the Rotterdam criteria. It's called Rotterdam criteria. Okay, what is this Rotterdam criteria? There are three things in the Rotterdam criteria. Number one will be an ovulation. Number one will be an ovulation. If I talk about number second, that is hyperandrogenism. Increased androgens will be there, guys. Okay, and number third, guys, plus minus look on the USG. What will be the number third, guys? Plus minus look on USG. Okay, so three things we have an ovulation, we have hyperandrogenism, and the third thing we have plus minus look on USG. Okay, now my dear students, if I talk about plus minus look on the USG and ovulation, the ovulation is not happening, guys. So that's why patient is complaining of amenorrhea. Patient is not bleeding from 2 months, 2.5 months, irregular cycles. Okay, hyperandrogenism, that's why patient is having hirsutism and acne. And the look on the USG will be like the pearl of string appearance. Okay, necklace or the pearl of string appearance. This will be the picture, guys. Putting the picture here. Okay, you can see, guys, this is a classical picture of this is a classical picture of polycystic ovarian disease. And don't confuse this picture with ovarian hyperstimulation syndrome. Okay, I will show you OHSS, ovarian hyperstimulation syndrome picture as well. These two questions are often asked, guys. So this one, it is ovarian hyperstimulation syndrome. Okay, ovarian hyperstimulation syndrome, this one. Okay, and this one is polycystic ovarian disease. Is it clear, guys? Two pictures that they can ask. Okay, after that, guys, in PCOD, if I talk about in PCOD, remember, guys, the reason of the bleeding in normal cycles we have progesterone withdrawal, but in PCOD we have ischemic withdrawal, because when there is no progesterone, estrogen action on the endometrium is the proliferation of the endometrium in a proliferative phase, or what you call is follicular phase. Endometrium keeps proliferating, it keeps growing, and at the end what happens, guys? At some point there is ischemia occurring, and the withdrawal, that is ischemic withdrawal. The withdrawal, that is ischemic withdrawal. Okay, so ischemic withdrawal is seen in polycystic ovarian disease. Number one thing, guys. Number second thing is the treatment of this PCOD. Okay, guys, in PCOD the multiple things are being involved. When there is a thick stroma, the glucose, the energy is not getting into the follicles. That's why follicles are not able to grow. So for that resistance, we give what? Metformin as a treatment. For acne, if I talk about main treatment for the hirsutism, that's what question says. If I talk about main treatment for the hirsutism, first of all, guys, if I talk about first treatment is due to the hyperandrogenism. So what is the first line, guys? We will give anti-androgens. we'll give anti-androgens. Number second, guys, we can give the first line management drugs like a potassium sparing diuretic, spironolactone. We can give spironolactone. Okay, we also use 5 alpha reductase inhibitors like finasteride, and we also use cyproton acetate. Okay, this is a classical treatment for what? Hirsutism in PCOD. Okay, guys. Yes, there are ovarian drilling, history of IVF. Yes, those people who are going for the IVF, those students, patients who are going with the IVF, the first step of the IVF is what? The first step of IVF is stimulation therapy. Okay, what is the injection you will give in stimulation therapy, guys? We give, to stimulate the follicles, we give FSH injection. Okay, guys, we'll give FSH injection to stimulate the ovaries, okay, follicles. Okay, and once we are giving that, what happens, guys? The complication can happen, ovarian hyperstimulation syndrome. Is it clear, guys? Yes, after that you take on the 14th day. Okay, I will be explaining a bit. What do you do in IVF, guys? First of all, you will stimulate the follicles, the ovaries, with the FSH injection. Then on the 14th day of the ovulation, you will take, under the general anesthesia, will take these follicles out. Okay, prepare the sperm, fertilize them, and put the embryo in the, guys, uterus with the help of a cannula implanted. So that's the process of IVF. And the frozen embryos you will put, where, guys? Yes, HMG is a, yes, if the question comes, an ovulation treatment in case of a IVF, you use HMG. If the question comes, an ovulation drug used generally for infertility, your answer goes to the clomiphene citrate. And if it says that drug of choice for an ovulation in PCOD, your answer goes to the letrozole. Yes. Is it clear? Clomiphene citrate also you can use. Yes, so there are 3 scenarios I'll be writing, guys. Good knowledge, all of you guys. Yes, you are answering very right. So drug of choice for an ovulation, if the question mentions drug of choice for an ovulation, your answer goes to clomiphene citrate. Okay, if drug of choice for an ovulation in PCOD comes, your answer will be aromatase inhibitor letrozole. Your answer will be letrozole. Okay, drug of choice for an ovulation IVF में क्या लगाओगे? HMG. Okay, if related to the pituitary, guys, you go with the GnRH pulsatile form. Is it clear? So all these 3-4 scenarios I've told you what to mark the answer. Okay, pituitary causes में GnRH analogs like boserelin, naferelin, goselerin. So that will be the treatment. Yes, you will store the embryos in the liquid nitrogen. Chalo, guys, done. So that was all about. Chalo, is it clear, guys? Now, yes, the surgical treatment for PCOD. Yes, there is a surgical treatment as well. I'm writing, guys, the surgical treatment. Now, one more thing, you will write it here, guys. We can also go for hirsutism. We can also go for cosmetic surgery. हम क्या कर सकते हैं और cosmetic surgery, because some females, they will get depressed due to the hirsutism, okay, due to the beard. So what will happen? We can go for the cosmetic surgery, and it will also decrease chances of depression as well. Okay, now the surgical treatment, there is a thick ovarian stroma. So in order to decrease the size of that stroma, you can go with the ovarian drilling. You can go with the ovarian drilling. What will happen, guys? The stroma will be thin then, and there will be enough glucose to the follicles, and follicles will grow, and the follicles will grow. Is it clear? Yes. The another name, yes, the another name for PCOD, guys, the another name, it's also known as Stephen-Leventhal syndrome. It's also called as Stephen-Leventhal syndrome. Okay, and you will remember Hyran as well. We also see, due to the insulin resistance, my dear students, we also see the cutaneous marks of insulin. What are those cutaneous marks? Called as acanthosis. HA will be hyperandrogenism, IR will be insulin resistance, and AN will be acanthosis nigricans. So acanthosis nigricans, okay, acanthosis nigricans is a black thick skin, leathery skin, guys. It is seen in the PCOD patient as well. This acanthosis nigricans is seen in the PCOD patient as well. Number 1 point, it is seen in the diabetes mellitus as well. Okay, this acanthosis nigricans. But guys, this is also a paraneoplastic syndrome. in case of a dermat view, the paraneoplastic syndrome from the skin point of view is acanthosis nigricans. And remember, which cancer, can you answer me, which cancer is associated with acanthosis nigricans? These are non-cancer conditions. PCOD ho gaya, diabetes ho gaya. But if I talk about paraneoplastic syndrome, okay, what are paraneoplastic syndrome associated with the cancers? Okay, which condition, which cancer is associated with the acanthosis nigricans? किस कैंसर के साथ दिखता है हमें ये? Acanthosis nigricans will be associated with which cancer as a paraneoplastic syndrome? You might have studied in neoplasia. Small, yes, gastric cancer is one right answer. One is gastric cancer. Very good, excellent guys. Gastric cancer and oat cell cancer. Oat cell carcinoma. Small cell carcinoma lung. Very good. Where what is the classical thing you will see there guys? Azopadi effect bhi milta hai. Chalo, I will not go there. It's a discussion of an obstetrics and gynecology. But yes, remember that acanthosis nigricans, it's also seen in the case of inflammatory bowel disease, diabetes, PCOD. But if I talk about cancers or the malignancies that are associated with this acanthosis nigricans, that are small cell carcinoma, lung, and oat cell cancer. Okay, the classical finding of this oat cell cancer in pathological point of view will be क्या मिलेगा guys? Azopadi effect. Azopadi effect. Okay, so that's all about PCOD. Okay, and this appearance is called ring of pearl appearance. क्या बोलते हैं इस appearance को? Ring of pearl appearance. Ring of pearl appearance. Is it clear? Yes, all clear guys. So that was all about PCOD. Now, which of the following drug is used in hirsutism? That was the question guys. Now what will be the answer? What will be the answer after discussing whole polycystic ovarian disease? What will be your answer guys? Metformin, OCPs is also used as a treatment for hirsutism, bromocriptine, or all of the above? Write down in the comment section everyone. Very good guys, it's OCPs with cyproterone acetate. Okay, OCPs with cyproterone acetate. Metformin, yes, metformin is used in PCOD, but for what? Insulin resistance. Okay, all of the above to answer hoga nahi. Bromocriptine, sir, what is the action of this bromocriptine? Chalo, bromocriptine I will discuss a little bit. What class of drug is this bromocriptine? Kahan pe discuss karu guys, let me write it here. Okay, this bromocriptine, students, this bromocriptine, okay, it's a treatment for hyperprolactinemia. Okay, it's used in hyperprolactinemia. What is hyperprolactinemia? When there's increased prolactin in the body. Now if we know from the biochemistry guys, what is the inhibitor of this prolactin? Dopamine is the inhibitor. Okay, so what is the drug you will give in case of hyperprolactinemia? Sir, I will use dopamine receptor agonist. Okay, so which class of drug is this? It's dopamine receptor agonist. It's a dopamine receptor agonist used in hyperprolactinemia. So, okay guys, done. Hyperprolactinemia. Other drug we also use cabergoline. The other drug we also use in case of this is cabergoline. The another drug that we use is cabergoline. Yes, it's a dopamine receptor agonist. Hyperprolactinemia. Clear? Yes, this can also be the cause of amenorrhea as well. Okay, if something wrong with pituitary guys, prolactin, FSH, LH, all coming from there, yes, amenorrhea can also be associated. So that's why the PCOD or the pregnancy is not only the cause of this amenorrhea as secondary amenorrhea. There can be something related to the pituitary as well. Sometimes like pituitary disorders, like tumors, craniopharyngioma ho gaya, pituitary adenoma ho gaya. So when the hormones are not coming, so that can be the cause of a secondary amenorrhea as well. Okay. So guys, it's all about PCOD. Is it clear guys? Write down in the comment section so we can go to the next topic. Remember guys, Rotterdam criteria. Remember these three things. Anovulation. I already told you the treatment for anovulation. The first line management will be, the first line management for ovulation, anovulation in the PCOD will be aromatase inhibitor, letrozole देंगे, ठीक है ना? Letrozole को याद रखना. First line will be letrozole in PCOD. Okay, if not in PCOD, then clomiphene citrate. Good. Yes. Chalo. Yes. Now to the next question. Now let's go to the next question. A 30-year-old woman who presented with second secondary dysmenorrhea. A 30-year-old woman who presented with secondary dysmenorrhea has been diagnosed with the endometriosis. So a 30-year-old patient is coming with the complaining of pain during the menstruation. What is the pain during the menses called? So it's called dysmenorrhea. Okay. And which of the following drugs is not useful in treating his patient? Which of the following drugs is not useful in treating this patient? So what will be your answer, guys? What will be your answer? Okay, you're getting answers right, but main important motive of this session is to discuss the whole topic. So whatever will be the questions, guys, focus more on the discussion rather than on the questions. Okay, so discussion is the more important because the questions will not be repeated, the topics will be repeated. Okay, chalo. Now first of all, guys, the first line that is in the question, guys, secondary dysmenorrhea. Now what is secondary dysmenorrhea, guys? You already know, guys, there are different types of dysmenorrheas in case of a patient when patient is bleeding. Okay, so what can be the different types of dysmenorrhea? First I'll discuss it here only, guys. Chalo. Number one, sir, there can be a primary dysmenorrhea. Yes, there can be a primary dysmenorrhea. There can be a secondary dysmenorrhea. There can be a secondary dysmenorrhea. There can be third one called as membranous dysmenorrhea. Third one will be membranous dysmenorrhea. So let me tell you in a brief way all of these, guys. Primary dysmenorrhea is when a patient having a pain 10 to 15 minutes prior to the cycle or prior to the menses. Okay, 10 to 15 minutes prior to the cycle, guys, it's a bleeding, it's a primary dysmenorrhea. If it occurs 3 to 4 days before the menses, it's called as secondary dysmenorrhea, which is classically seen in, guys, this secondary dysmenorrhea is classically seen in PID and endometriosis. Okay, if you remember from my full workbook of obstetrics and gynecology, I have clearly mentioned over there that secondary dysmenorrhea is seen in typically with endometriosis and PID. Okay, and membranous dysmenorrhea, guys, there is a fibrinolytic system in our body that helps in a less clumping of the blood. Okay, when a female bleeds, guys, if there are more clots, what will happen? Cervix needs more dilatation. When the cervix needs more dilatation, it needs more contractions. When it's more contractions, my dear students, when it happens with a more contraction, what will happen? More pain will happen. Are you getting my point? More pain will happen. So if this fibrinolytic system in our body is absent, this fibrinolytic system in our body is absent, okay, what will happen? There will be more clotting of blood, more clumping or clots. They will need more contractions. When there are more contractions, there need be more pain. Such a pain, my dear students, is called as membranous dysmenorrhea. Such a pain is called as membranous dysmenorrhea. So it is clear, guys, what are the different types of pains we have during the menses. We have primary dysmenorrhea, we have secondary dysmenorrhea, we have membranous dysmenorrhea. Is it clear to everyone? Yes. Now the patient is coming with the diagnosis of endometriosis. Okay, now this endometriosis, let's write it now. Now this endometriosis we'll be discussing what exactly is endometriosis. Okay, if I talk about first of all the etiology of this endometriosis, sir, what is the cause of this endometriosis? It's due to the retrograde menstruation. Okay, there are a lot of theories on that, but the accepted theory is due to the retrograde menstruation. Okay, what is this retrograde menstruation, guys? It means the backflow of menses. It means it's due to the backflow of menses. Okay, when there is a backflow of the menses, guys, the patient who are weak, who are immunocompromised, they develop endometriosis. Endometrium tissue somewhere else is endometriosis. Okay, now my dear students, if I talk about most common site, this can be the question asked. The most common site of this endometriosis, it can be first one, your answer will go to the ovary. Okay, second most common site, if I talk about second most common site, your answer will go to the pouch of Douglas. Okay, rest, it can be also present in the bowel, it can be present in the eyes. ठीक है ना, यहाँ सब मिलेगा, nose, this endometriotic tissue. But your first will be, most common site will be ovary, followed by pouch of Douglas, okay. Now how will the patient present, my dear students? Remember guys, there are classical D's seen in the patient. First of all, the age of the patient will be third to fourth decade, that's around 25 to 35. The age of the patient will be third to fourth decade, complaining of dysmenorrhea, okay, pain during the menses, complaining of dyspareunia, okay, painful intercourse, complaining of dyschezia, painful defecation, complaining of dysuria as well. Okay, they are classically seen in, what is the diagnosis guys? You have a 25-year or 35-year-old lady coming with the complaints of dysmenorrhea, dyspareunia, dyschezia, all these symptoms. This is a classical case. Your first differential diagnosis will be endometriosis. Then later on, while we'll confirm with the investigations for this endometriosis. Now, if I talk about investigations, that was the question asked in this recent FMG exams, January guys. Investigation. Now, investigation, you can go with the USG, you can go with the MRI to exactly look these tissues. But investigation of choice will be, my dear students, diagnostic laparoscopy. What will be the investigation of choice, my dear students? Laparoscopy. And this was the question asked this exam. What is the investigation of choice? What is investigation of choice in the endometriosis? What is the investigation of choice in the endometriosis? Is it clear? So laparoscopy is the investigation of choice. Now, what are the findings on the laparoscopy, guys? Right, on laparoscopy, we'll see powdered burn lesions. We'll see these powdered burn lesions. Number one thing. Number second thing, guys, old blood, small clots and this debris, old blood, these clots and this debris will be accumulated in the cyst called as chocolate cyst. Okay, and these patients of endometriosis, guys, due to the additions, they will rarely have infertility as well. Rare hota hai, but remember guys, infertility bhi hota hai. Infertility as well. Okay, second is chocolate cyst. Third, guys, finding, we have also uterosacral ligament nodularity. Okay, these classical three things, if presented in the question, in the findings, your answer goes to endometriosis. Always try to find these highlight points. Always try to find in the question these highlight points. So if powdered burn lesions are there, if it's mentioning chocolate cyst, if it's mentioning uterosacral ligament nodularity, your diagnosis is endometriosis. Now, my dear students, what is our main goal now in endometriosis? Sir, there is a what is the reason, guys? There is an increased estrogen which causes proliferation of this endometrium. So there is a hyperplasia of these endometrial glands. Okay, what is hyperplasia? Hyperplasia means when there is an increased number of cells. That goes to the hyperplasia. Okay, now what do we have to do, my dear students? We have to do atrophy of this endometrium. Now, treatment. So what will be the treatment? First of all, my dear students, we'll start with the drug called as DMPA injection, depot medroxyprogesterone acetate. What does this drug do, guys? Atrophy of endometrium. It will cause atrophy of endometrium. Now, after the atrophy of endometrium, we know which hormone is responsible for the hypertrophy. Hyperplasia के लिए कौन responsible है? Estrogen. So what is the second drug I will use? I will use anti-estrogen. Which drug, my dear students? I will use danazol. क्या use करोगे? Danazol. It's a first line management and it does faster atrophy. ये जल्दी कराएगा atrophy. It does faster atrophy of the endometrium. Okay, but the main point you will remember, guys, the side effect of this danazol, it is virilization. What is the side effect of this danazol, guys? It is virilization. So what is virilization? Remember the three things, guys. There is breast atrophy. Number one. Number second, there is clitomegaly. And number third, my dear students, there is hoarseness of voice. hoarseness of voice. Okay, the question was asked that which of the following, the question was asked which of the following symptom you see and you have to stop the danazol. Okay, you have to stop the danazol. Okay, hoarseness of voice. So if there's a hoarseness of voice, you have to stop this danazol as drug. Okay, then guys, you already know guys, we can use another drugs as well. Okay, like OCPs, we can use OCPs as well. Okay, you can directly decrease the excretion of the estrogen because estrogen is coming from FSH is coming from the pituitary. So you do the down regulation of the pituitary with the drugs GnRH analogs. GnRH analogs ke sath you can do the directly down regulation of the pituitary. So what will happen? Atrophy of the endometrium will happen. So endometriosis, it's more about a medical management. Why? Because you cannot go for the hysterectomy. Patient is only third to fourth decade. Is it clear guys? So never mark hysterectomy as the answer. Number first thing. Number second thing is, sir, for adhesions in this endometriosis, क्या करोगे इनके लिए? Adhesiolysis. And for this chocolate cyst, okay, for this chocolate cyst, okay, why it's chocolate? Because old debris, blood इसमें जमा हुआ होता है, fluid. Okay, chocolate cyst, there is no chocolate present there. Chalo, chocolate cyst. Okay, for that you will do cystectomy. For that you will do cystectomy. Now two questions. FMGE last year 2023 June, it was asked what is the treatment for recurrent cyst. Your answer is cystectomy. This exam question, what is the investigation of choice? Your answer is laparoscopy. So guys, what is the main goal of the treatment here? We have to give anti-estrogens because estrogen is already proliferating this endometrium, this proliferating. So your treatment will be anti-estrogen, danazol. So the question says, which of the following is not the drug useful in treating this patient? What will be your answer? Which of the following drug is not useful in this patient? Okay, your answer goes to, yes, your answer goes to everyone. What will be your answer? What will be the answer, guys? Yes, sir, estrogen. Okay, progesterone we already use in case of DMPA, depot methoxyprogesterone acetate. Danazol, it's also used as an anti-estrogen. Okay, GnRH analogs, down regulation of pituitary. Down regulation of pituitary. Very good. So your answer goes to estrogen. Now, is all endometriosis clear, guys? Every one of you? Okay. Can endometriosis cause endometrial cancer? No. Okay, endometrial cancer, classical picture of a patient who will be obese, hypertensive, and diabetic, giving a history of a post-coital or the post-menopausal bleeding. Okay, but here guys, is it clear? Which drug causes endometrial hyperplasia? Yes, a drug that causes endometrial hyperplasia, ये बात भी बता देता हूँ. The drug which causes endometrial hyperplasia it is a selective estrogen receptor modulator, SERM. The drug is SERM, selective estrogen receptor modulator. The drug name is tamoxifen. ठीक है ना? Tamoxifen. Okay, what is the side effect of this tamoxifen? Sir, it causes endometrial hyperplasia. It causes endometrial hyperplasia. That's why rather than using this tamoxifen, we can use another drug called as raloxifene. Okay, there is no side effect of raloxifene. That is also used in a treatment for osteoporosis. Okay guys, is it clear? Write down in the comment section guys, is it these three topics cleared? So make sure that if any question from these three topics, three questions we have discussed so far, any single question from these three topics, you have to mark that no matter what. Is it clear? Crystal clear. It should be crystal clear guys. This much in the rapid revision or the discussion is more than enough if you remember this much. Can I go to the next topic? Chalo. Yes, sir. Perfect. Now, my dear student, the next question is, which of the following is not included in the active management of third stage of the labor to prevent postpartum hemorrhage? So the questioning from the AMTSL criteria, guys. So we have to remember the steps of this active management of third stage of the labor. So I've already discussed, guys, the third stage of the labor. I've already discussed that it's a delivery of the baby to the delivery of placenta. It's delivery of the baby to the delivery of placenta. Usually it's 10 to 15 minutes, but when it's prolonged or when it takes more than 30 minutes, बच्चों क्या होता है? So it causes postpartum hemorrhage. We call it as prolonged third stage of labor or retained placenta or retained placenta. Chalo. Now let's discuss. Now, in order to prevent such complications, what can be the complications, guys? What can be the complications? So the complications can be, there can be a postpartum hemorrhage. So there can be during the delivery of the placenta in the third stage. If we go for the sudden cord traction, so there can be a uterine inversion, number one thing. So there can be the bleeding called as postpartum hemorrhage. With this bleeding and excessive bleeding, patient can be the shock. So shock is the complication of this. Are you getting my point, guys? So all these reasons are the complications of the third stage of labor. Are you understanding my point? Now, in order to prevent these complications, in order to prevent such complications, we have a management called as active management of third stage of labor. What is the management, bacho? We have a management called as active management of third stage of labor. Okay, active management of third stage of labor. So third stage of the labor, guys, third stage of the labor, I will write it here, active management of third stage of labor. Okay, now what is this third stage of the labor, guys? It's a delivery of baby to delivery of placenta. It's delivery of baby to the delivery of placenta. Delivery of baby to the delivery of placenta. Okay, now my dear students, the usual time is 10 to 15 minutes, and if this third stage takes more than 30 minutes, if this third stage of labor takes more than 30 minutes, I call it as prolonged third stage of labor or retained placenta beds Now we have four steps. In this active management of third stage of labor. Okay, what can be the complications? First of all, let's write the steps, guys. Step number 1, we can administer the uterotonic agent. Step number 1, guys, administer the uterotonic agent. What is the uterotonic agent that we'll use? Because you already have discussed in the first question, guys, that sir, we have to maintain the tone of the uterus. So you'll use uterotonic agent, oxytocin. क्या यूज करते हैं हम? Oxytocin as uterotonic agent. That's why I have mentioned over there, to prevent the PPH, my dear students, we use prophylactic drug. As oxytocin. कौन सी drug use करते हैं as prophylactic? We use oxytocin. How much? 5 to 10 units for the prophylaxis. कितना करेंगे use? 5 to 10 units. The question was asked in the recent exams. That was the state exams for being a medical officer. It was mentioned what will be the dosage of an oxytocin in AMTCL. Okay, and you have to remember the dosage, 5 to 10 units. In the option, it was also 20 units given as well, 30 units as well, but your answer goes to the prophylaxis ke liye 10 units. That is the step number 1. If I talk about step number 2, that is delayed cord clamping. What is the step number 2, guys? Delayed cord clamping. Okay, if I talk about step number 3, that is delivery of placenta. Okay, sometimes when in exams they will mention rather delivery of the placenta, options may they will play with you. They can write control cord traction. They can write control cord traction. एक ही बात है, because how the placenta is delivered, guys? Control cord traction, or the, which is also called as Brand and Andrews method. Let me show you the picture of control cord traction, guys. Control cord traction. This is a control cord traction. Okay, the picture is control cord traction. You try to move slowly the cord so that the placenta will be detached from the netabus layer and there will be a smooth removal of placenta. So, okay, so control cord traction means a delivery of the placenta. So sometimes they will mention that which of the following is not included which of the following is not included? So make sure that you answer right. Okay, so control cord traction. If I do sudden cord traction now see why this control cord traction is in the active management of third stage of labor. Now if I suddenly remove the cord, what will happen, my dear students? A bleeding will happen, postpartum hemorrhage will happen. If this placenta is closely attached to the uterus, or it goes to the myometrium or uterine muscle, in case of an adherent placenta, what will happen? Uterus will also come out, turning upside down of the uterus. What is that condition called? Sir, uterine inversion can happen, which is then also complication of which stage of labor, bacho? Third stage of labor. So that's why control cord traction is the active management of third stage of labor in order to prevent the complications like postpartum hemorrhage and uterine inversion. Okay, chalo, control cord traction. After that, step number 4 will be assessment or observation. Assessment, observation. Assessment of uterine tone or observation. Okay, so these are the 4 steps. Now the question was, which of the following is not included? Now answer, guys, in the comment section faster. Now, which of the following is not included in the active management of the third stage of labor to prevent postpartum hemorrhage? Which of the following is not included? Which of the following is not included? Yes, injection carboprost. Okay, injection carboprost is not included in active management of third stage of labor. Okay, so uterine tonic within the 1 minute of delivery, yes, you have to give. Delayed cord clamping, yes, more blood will go to the fetus. Early cord clamping, what can be the indications, bacho? So birth asphyxia, any congenital heart disease, at that time there's an indication of the early cord clamping. After that, controlled cord traction, which is also known as Brand and Andrews method. It's a method of delivering the placenta. Okay, if any question coming, I'll be discussing that as well. How to deliver the placenta, what are the placental separation signs? For example, there will be a gush of blood. Okay, in any question I will mention that in a detail. Chalo, so is it clear, guys? Active management of third stage of labor. Why we are going for this active management of third stage of labor? In order to prevent the complications. What can be the complications? The uterine inversion or the postpartum hemorrhage. So how this delivery of placenta can cause the PPH? I've told you, if we go for the sudden cord traction, suddenly nikaloge to kya hoga? Uterine inversion hoga, bleeding hoga, patient will have a neurogenic shock first, followed by hemorrhagic shock, patient will die. Now what will be the treatment? Directly push the uterus back. So it is clear, guys? Yes, you all are right. See, injection carboprost. Okay, injection carboprost. Everyone correct. Chalo. Moving to the next question. Perfect. Are you understanding, guys? I am a bit faster, but it's a discussion. I hope you have revised this from your main notes. Whatever source you have studied, you have revised this, and already OB-GYN videos are still in the channel. You guys have watched that. Chalo. Now let me move to the next question, guys. Which of the following complication is unlikely in a patient with gestational diabetes? Which of the following complication is unlikely? Okay, which of them is not found in the GDM? Okay, you will not see in the gestational diabetes mellitus. So type your answers, guys. Let me see what your answers, and then I will discuss this. At least this one is an easy go. Chalo. Perfect. Yes. Some right answers. Very good. No problem. Those who are marking wrong, no problem. I will guide you. I will tell you what exactly to go with. Chalo, guys. Okay, so let's discuss, guys, gestational diabetes mellitus. Let's discuss with the gestational diabetes mellitus. Okay, so remember, first of all, guys, this gestational diabetes mellitus, what is GDM, guys? Diabetes in pregnancy, it's called gestational diabetes mellitus. But if a patient is already having GDM, now GDM is more than 24 weeks onwards. When the pregnancy is more than 24 weeks, then only you can call it as gestational diabetes mellitus. Now you have a female, she's diabetic before the pregnancy. Okay, if before the pregnancy, okay, if diabetes before pregnancy, before pregnancy, what I will call it? I will call it as overt diabetes mellitus. I will call it as overt diabetes mellitus. But in pregnancy, more than 24 weeks occur, I will call it as gestational diabetes mellitus. Okay, if it pregnancy in a previously normal woman, if it occurs more than 24 weeks, I will call it as gestational diabetes mellitus. Okay, now sir, why this GDM is occurring? Remember that two hormones, human placental lactogen and estrogen, human placental lactogen and estrogen, guys, they have insulin like action, insulinase like action, okay, which will cause what? Insulin resistance. क्या होगा इनको guys? Insulinase like action. There will be insulin resistance. When there will be insulin resistance, what will happen, my dear students? Increase blood sugar levels, increase blood sugar levels. So that is the cause of GDM. But how many weeks onward it occurs? More than 24 weeks onwards. Okay, now the question, in which of the following diabetes the congenital anomalies will occur? Which of the following diabetes congenital anomalies will occur? Over diabetes, GDM or both? Answer in the comment section. कहाँ पे मिलेगा guys? Overt. Answer in the comment section. Yes, insulin resistance will lead increased blood in the blood. Yes, you are right. Answer in the comment section, guys. What can be the reason? Which of the following will have a congenital anomalies associated? Over diabetes or GDM or both? Yes. Some right answers, some wrong as well. Okay, good. Chalo guys, if you don't know the answer, no problem. Now what happens, guys? Organogenesis takes place in the first trimester onwards, okay, and it's in the late pregnancy. 24 weeks के बाद हो जाता है GDM. So obviously the over diabetes will be associated with the congenital anomalies, okay, but GDM will not cause anomalies, okay. Now congenital anomalies, that I will tell you in the in some point, guys, in a few minutes, that what can be the reasons of NTDs, macrosomic baby, polyhydramnios. Chalo. Now now first of all, guys, what are the features of this GDM? Now increased blood sugar is there, okay. What are the features? Now when there is the infant, okay, let me start from here. The infant of this GDM will be hypoglycemic. ये बात याद रखना, guys. It will be hypoglycemic. Why it will be hypoglycemic, guys? Because there is a beta cell, there is a hyperplasia, because there is a hyperplasia of beta cells of pancreas. Okay, उसकी वजह से क्या होता है, guys? The baby is hypoglycemic. But when the baby is hyperglycemic, okay, more urine, okay, when there is a more urine, what is the amniotic fluid constituent? What is the main constituent of the amniotic fluid after the 20 weeks onwards? So main constituent after 12 to 20 weeks onwards is what? It is fetal urine. And now first the baby is hyperglycemic. Okay, when the baby is hyperglycemic, there is more polyuria. What will happen? This polyuria, okay, polyuria, fetal urine increased, okay, increase amniotic fluid, increase amniotic fluid. What will happen, guys, when the amniotic fluid is increased? So baby will have polyhydramnios. Baby will have polyhydramnios. In GDM, guys, increased growth hormone factors, okay, there are increased growth hormone factors, increase growth hormone factors in GDM. So what will happen, guys? Baby is macrosomic, okay. So when the baby is hyperglycemic, this increased glucose is converted into the fat. That's why the baby is what? Macrosomic. So what is macrosomic baby? More than 4 kg. Number second thing. Okay, number third thing, when this baby is macrosomic, guys, it is difficult to deliver. It is difficult to deliver normal vaginal delivery, so more chances of obstruction will be there, more chances of pph will be there. That's what I mentioned, guys. Atonic uterus, over distension of the uterus in the beginning of this session, guys. Atonic uterus or the over distension of the uterus. When there is a atonic uterus or the over distension of the uterus, more chances of postpartum hemorrhage. And when the baby is big, exactly, you're right, there are chances of shoulder dystocia. There are chances of shoulder dystocia. Okay, more chances you have to go for episiotomy as well, so that the baby will be passed very easily. Okay, so is it clear, guys? Shoulder dystocia. What is the maneuver that we use? Mac Roberts maneuver, mainly Mac Roberts maneuver. There are other maneuvers as well. Itna yaad rakho, Mac Roberts maneuver. Is it clear? So shoulder dystocia will be there, macrosomic baby will be there, baby will be hypoglycemic. Okay, but due to the hyperplasia of beta cells of pancreas. Is it clear, guys? Yes. pph obstruction, overall delivery related complication occurs. Yes, Mac Roberts maneuver. Very good, very good. Chalo, guys. Now now the question was mentioning that unlikely in the patient of gestational diabetes mellitus. What is your answer now? Sir, macrosomic, yes. Sir, can it cause abortion? Yes. Preterm labor and abortion. Sir, can it cause if uncontrolled? See, GDM is a high risk pregnancy. Okay, GDM is a high risk pregnancy, so it can cause abortion as well. Okay. Now, can it cause oligohydramnios? No, sir, it will not. It will cause polyhydramnios. So, what is oligohydramnios? It is amniotic index less than 5 centimeters. Okay, the causes can be the renal causes. Remember that, or leaking, or amniocentesis, or the drugs like NSAIDs or AC inhibitors. What will those drugs do, guys? They will decrease the fetal urine, and any condition, anything wrong with kidneys, or any single drug that will inhibit the fetal urination, that will decrease the fetal urine, is a classical cause of a oligohydramnios. Because what is the main constituent of the amniotic fluid, bacho? What is the main constituent of this amniotic fluid? It is a fetal urine only. So if there is inhibition of the there is a decreased glomerular filtration rate, what will happen? Decrease fetal urine. What will happen? Decrease amniotic fluid, oligohydramnios. One single thing I will also tell you about oligohydramnios. Write it down, guys. Preeclampsia. In preeclampsia, there is a decreased blood flow to the kidneys. There is a decreased blood flow to kidneys. When there is a decreased blood flow to kidneys, क्या होता है उसके बाद? There is a decreased GFR. When there is a decreased GFR, तो उसके बाद क्या होगा? There is decreased fetal urine. When there is decreased fetal urine, there is decreased amniotic fluid, which is called oligohydramnios. So renal agenesis, anything related to the kidneys, will eventually affect the urine formation, and eventually it will cause oligohydramnios. So in gestational diabetes, guys, when a baby was hyperglycemic first, what was happening? Polyuria. What is the function of this? What is the classical symptom of this diabetic? पढ़ा तो है, polyuria, polyphagia, polydipsia. तो polyuria हो गया. And when there is an increase fetal urine, it will surely cause polyhydramnios. Okay. Yes. Oligohydramnios in severe cases, that is Potter's triad or Potter's syndrome. Okay, there will be a limb hypoplasia, guys. I will show you the one picture. You don't go there, it's a discussion, I don't want to go deeper, but yeah, chalo dekh lo. See, this is a severe oligohydramnios. Patient is having a Potter facies, limb hypoplasia, and bilateral renal agenesis. So baby will be severe oligohydramnios, called as Potter's triad or Potter's syndrome. Clear, guys? So what is the complication in the GDM? Complication will be shoulder dystocia and obstetric injuries. Okay, now did you understand this much? Did you understand this much, guys? All of you? Yes, sir, the treatment. Okay, treatment, remember, guys, regular insulin is the treatment. Regular insulin. Okay, followed by that orally we will give metformin, which is a bicarbonate having a side effect of lactic acidosis. Metformin कौन सा class है drug? Metformin. Sir, your explanation is really great. I'm a nursing student. I can understand everything so well. Thank you. You're welcome. Oral metformin. Okay, it's a class of a biguanides. Okay, biguanides a class का. And the side effect of metformin is lactic acidosis, याद रखना. And another drug is glyburide, which is a sulfonylurease. What is the side effect of the sulfonylurease? Hypoglycemia. Hypoglycemia. And this preeclampsia, सुन लो GTX. This preeclampsia, when there is a decreased blood flow to the like how this preeclampsia disposed to the eclampsia, when there is a decreased blood flow, because more than 140 by 90, what is preeclampsia? Okay, more than 140 by 90. No, it's not a DMARD. Okay, DMARD नहीं है ये, biguanide है, ठीक है, Dr. Phoenix. Okay, now सुन लो, when the preeclampsia blood pressure is more than 140 by 90, along with that there is a proteinuria present. उसके बाद क्या होगा? There will be decreased blood flow to the brain as well. Okay, when there is a decreased blood flow to the brain as well, क्या होगा? ऑक्सीजन कहाँ से जाता है ब्रेन में? With the blood only. When there is a decreased blood flow, क्या होगा पेशेंट को? Cerebral hypoxia होगा सर, cerebral hypoxia. When there is a cerebral hypoxia, what will happen? Convulsions. When convulsions are added, it becomes eclampsia. So we have to control preeclampsia. Okay, what will be the signs? There will be blur, vision, nausea, vomiting, epigastric pain. Okay, knee reflexes को, so सारा तो eclampsia हो जाएगा. Okay, so how do you control this? How do you, yes, seizures will be added. Now how do you control this patient? How do you control this patient having what? How do you stop this patient going to the eclampsia? Okay, control the blood pressure, start the prophylactic magnesium sulfate. So this all will be this all will be controlled. Okay, now this much is enough, guys. But then the further, if we go to the kidneys, blood flow decrease to the kidneys, then classical finding of glomeruloendotheliasis. I will not go there. You just stick to this much, guys. This much for the GDM is more than enough. Itna is more than enough. Okay, and this time question was asked. This time the question was asked that after how many weeks the screening of GDM is done. After how many weeks the screening of GDM is done. So GDM screening कब करोगे, guys? 24 weeks onwards. When you will start screening of GDM, guys? 24 weeks onwards. Now what are the investigations for GDM? ये तो लिख दो, guys. Investigations, I'm writing here. Investigations, okay. It's called one-step test. Okay, one-step test. One more question: how much glucose you will give, बच्चों? You'll give 75 grams of glucose. Okay, first of all, the normal should be, okay, first of all, normal should be less than 92. Then after giving 75 grams of glucose, less than 180 should be in 1 hour. Okay, and less than 153 should be after 2 hours. Okay, if this is the condition, guys, no problem. But any one of them will be the confirmatory of GDM. Okay, if any one of these three will be deranged, this is a classical case of GDM. Is it clear? Diagnosis: HbA1c will be for the over diabetes, है ना? Over diabetes, if already over there, guys, क्या करोगे sir? HbA1c, ठीक है, more than 6.5 is a diabetes mellitus. More than 6.5 is a diabetic. Is it clear, guys? GDM is clear. Is GDM clear? Yes. Anything else? Yes, serum fructosamine levels also you check, but that is for the short term के लिए. Long term HbA1c. Now the patient is over diabetic, you go with the HbA1c. But in GDM we usually do one-step test, less than 92 in the normal levels fasting. Okay, 1 hour it should be 180, and after glucose 2 hours it should be less than 153. Okay, regular insulin is a treatment. Okay, but if oral hypoglycemic drugs, it's metformin and glyburide. It's metformin and glyburide. Is it clear, guys? All of you, everyone in the live? Yes, crystal clear. So GDM, all these 4 or 5 topics so far. Yes sir. Okay, complications. हाँ बता देता हूँ complications. So I'm writing complications here, guys. I'm writing complications here. Okay, most common neural tube defect associated in GDM. कौन सा है न्यूरल ट्यूब डिफेक्ट गाइस? मोस्ट कॉमन न्यूरल ट्यूब डिफेक्ट एसोसिएटेड इज sacral agenesis. It's sacral agenesis, also called as caudal regression syndrome. Caudal regression syndrome. Okay, sacral agenesis or caudal regression syndrome. Number one thing, if anencephaly is also associated, guys, anencephaly bhi hota hai, most common will be your sacral agenesis or caudal regression syndrome. Okay, most common heart defect, most common heart defect will be transposition of great arteries, TGA. Okay, followed by VSD. Is it clear? So VSD is also associated with what? GDM, but most will go with the transposition of great arteries, having an egg on string appearance on the chest x-ray. Okay, you might have seen that. Then sacral agenesis is the most common neural tube defect. Anencephaly. What is the sign in anencephaly, guys? कौन सी sign दिखती है हमें anencephaly पे? Sir, frog eye sign. Frog eye sign. All clear, बच्चों? Everyone, is it clear? We can go with the next topic, guys. So polyuria, increase amniotic fluid, polyhydramnios. Remember that microsomic baby increase growth hormone factors, and I've told you this glucose will be converted into the fats. Chalo, next question. Okay, a multigravida who had a normal vaginal delivery, develops postpartum hemorrhage. Okay, more obstetric questions in the beginning, guys. So far no gynecology questions. The third stage was managed actively and the placenta and membranes were expelled completely. Okay, the third stage was managed actively and the placenta and membranes were expelled completely. What is the first step in the management? Okay, so patient is having postpartum hemorrhage. What will be your first step in management? Chalo likh do, guys. What will be your first management? Okay, always remember, guys, carry out a uterine massage, give oxytocin infusion, palpate the uterus. Okay, first of all, guys, you will insert two 14 gauge cannulas and start the IV fluid. So always remember, guys, your first management is resuscitation. Your first management is resuscitation. Okay, in resuscitation, guys, what do you do? Okay, skewer the line, guys. Okay, by skewering the line, what do you use? 14 gauge cannulas. Okay, 14 gauge cannulas. If we talk about cannulas, guys, orange, gray, green, pink, blue, yellow, violet, है ना? It is 14, 16, 18, pink is 20, blue is 22, yellow is 24, violet is 26. Okay, the increased, okay, the beginning, guys, will be having an increased flow. Okay, so in case of traumas or emergencies, when you need fast transfusion, you go with the 14, 16, 18. Are you getting my point? And this 22, 24, 26 you use usually in the infants. Okay, उनकी skin भी is not developed, and elderly people, guys, so we usually use 22, 24, 26. But in case of an emergencies and traumas, we use 14, 16 and 18. Yes, exactly. White is 17. चलो लिख भी देता हूँ यार, white is 17. Is it clear, guys? So that is the first, always the first line management will be what? Skewer the line and resuscitation. Then followed by that, yes, you can go for the uterine massage, you can go for the oxytocin. Okay, so that is the further management. So any condition, for example, if in uterine inversion as well, your first management always is what? You insert the cannulas and skewer the line, so that try to make patient hemodynamically stable. Okay, and why? To prevent the shock. If there will be continued bleeding, what will happen to the patient will go into the shock. So skewer the line first. Okay, very basic question, guys. Insert two 14 gauge cannulas and start IV fluids. So the next question, guys. Chalo, a 24-year-old primary gravida at 30 weeks of gestation. Okay, so 24-year-old primary gravida is coming to you, 30 weeks of gestational age. Okay, for a regular ANC, she is coming for the regular antenatal checkup. On examination, the uterus corresponds to 34 weeks. That means over distension of the uterus, large uterus. Are you getting my point? Actually, she's how many months pregnant, guys? She's 30 weeks. Sorry, she's 30 weeks pregnant. But now, when you are going for upper abdominal examination, when you are going for examination, guys, you are seeing that it is 34 weeks. Kitna hai? 34 weeks. So 34 weeks, 36 weeks, its fundal height will be at the cephisternum. I've taught you in the normal classes, guys. I've taught in the normal classes that at pubic symphysis it's 12 weeks. Then at 24 weeks it's upper border of umbilicus. At 20 weeks it's lower border of umbilicus. And at 36 weeks it's cephisternum. Okay, in which condition it will be a lag, sir, in IUGR. Agar if the question mentioning that she's a 30 weeks of gestation but uterus is corresponding just 24 weeks, so you diagnose it as what? It's a clinical abdominal lag. That means the baby is small, intrauterine growth restriction, है ना? So that you diagnose with the IUGR. But now it's a big baby. Okay, uterus is corresponding to 34 weeks, so that means big uterus, and over distension of the uterus, you already know, twin pregnancy and polyhydramnios. So the gestational with normal fetal heart rate, TVS revealed AFI of 26 centimeters. So the amniotic fluid index is 26. Which of the following condition is mostly likely to be associated with this? So which of the following condition is mostly likely associated with this? Okay. Chalo guys, so let's understand first what is your diagnosis, guys. So its diagnosis is polyhydramnios. What is your diagnosis, guys? It's polyhydramnios. Okay, why? Because the AFI, amniotic fluid index, is 26 centimeter, because the amniotic fluid index is 26 centimeter. Now let's discuss one by one क्या है polyhydramnios and oligohydramnios. चलो, let me discuss, guys, polyhydramnios and oligohydramnios. Okay, so one side will discuss oligohydramnios, one side will be discussing oligohydramnios, and second side will be discussing polyhydramnios. Okay, now oligohydramnios means decreased amniotic fluid. Sir, how much decrease? When the AFI is less than 5 centimeters, when the amniotic fluid index is less than 5 centimeters. Number one thing. Number second thing, sir, causes. Okay, we already discussed something wrong with your kidneys. Okay, that goes with the bilateral renal agenesis. Okay, so the most common cause will be bilateral renal agenesis. The most common cause will be bilateral renal agenesis. Okay, the other causes, for example, now my dear students, the peak level of this amniotic fluid. Understand this amniotic fluid chapter, it's very important. I'm discussing every single bit of amniotic fluid dynamics. So whatever will be the question asked, this much is enough that I'll be delivering to you in the amniotic fluid. Okay, so what happens, guys, whenever in a normal pregnancy, okay, now fetal urine is contributing to this amniotic fluid. Is it clear? Now after that, what happens at 34 36 weeks? There is a peak level of this amniotic fluid. What is happening? There is a peak level of this amniotic fluid. After 36 weeks onwards, the amniotic fluid start decreasing. So it's assumed that, okay, 1000 ml at the peak level, 34 36 weeks, during that period it is 1000 ml, but at 40 weeks it goes to the 600 ml. So if there is a post-term pregnancy or post-dated pregnancy, okay, post-term pregnancy ho ya post-dated pregnancy ho, what will be the amniotic fluid, less or more? Sir, it will be less. So write post-term pregnancy after 42 weeks onwards. After 42 weeks onwards, already there will be what? There will be decreased amniotic fluid, oligohydramnios, or the drugs like NSAIDs. कौन सा NSAIDs? Endomethacin or ACE inhibitors. Those drugs will do what, my dear students? So they will decrease the urine output. So they will decrease the urine output. And when there will be decreased urine output, there will be oligohydramnios. There will be oligohydramnios. Is it clear? There will be oligohydramnios. Okay, even posterior urethral valve, that will also predispose to what? That will also predispose to the Oligohydramnios. If the baby is small, ठीक है, intrauterine growth restriction will be there. What will happen? Oligohydramnios. Oligohydramnios. Is it clear? So these can all be the reasons of what? Decreased amniotic fluid. And when there is a severe oligohydramnios, that's what we call as Potter's triad. When you have a limb hypoplasia with the renal agenesis and Potter's faces. Okay, so that's called Potter's syndrome or Potter's triad. Is it clear, guys? Oligohydramnios. So all this, even amniocentesis, if you go for the amniocentesis or for diagnostic amniocentesis, if you go for diagnostic amniocentesis, so what will happen? Decreased amniotic fluid, oligohydramnios. So this is all about oligohydramnios. If I talk about polyhydramnios का मतलब क्या होता है? When the amniotic fluid index is more than 25 centimeter. Now write down the causes, guys, over there. I will see. I've mentioned a few causes already, guys. What can be the cause? If I talk about most common cause, guys, that is idiopathic. Most common cause is idiopathic. But followed by that, we have causes. So remember, guys, if we have a twin pregnancy, what will happen? There will more urine. Okay, uterus is only one. Na? So twin pregnancy, 2 babies, polyuria, more urine. Are you getting my point? More amniotic fluid, polyhydramnios. So 2 babies always will have more fluid, more HCG, more vomiting, hyperemesis. So twin pregnancy goes to the polyhydramnios. Number second thing, guys. Number second thing is anything related GI abnormalities, congenital GI abnormalities. What can be the congenital GI abnormalities, my dear students? Remember that there can be a duodenal atresia. क्या होगा congenital GI abnormalities में? Congenital abnormalities में duodenal atresia. Number second will be esophageal atresia. Number second will be esophageal atresia. Okay, उसके बाद क्या हो सकता है? Cleft lip. Cleft lip palate. That can also cause. Okay, just now we discussed gestational diabetes mellitus. Gestational diabetes mellitus. That can also predispose to what? Polyhydramnios. Okay, twin pregnancy, duodenal atresia, esophageal atresia, all this can this will predispose to what, guys? Polyhydramnios, when the amniotic fluid is more than 25 centimeter. Very good. Now, guys, what will be the treatment for this? Okay, now let's discuss the treatment only here. So if there is a patient having what? If there is a patient having polyhydramnios, now the drugs that causes oligohydramnios will be the treatment in polyhydramnios. So I can use AC inhibitors, I can use GDM, sorry, I can use not GD, I can use NSAIDs. Okay, I can use NSAIDs. So what will they do, guys? They will cause decrease urine output. So further it will be treated. Or second, my dear students, I can go with therapeutic amniocentesis. What do I mean by therapeutic amniocentesis? When I use this amniocentesis procedure as a treatment, ठीक है ना, ट्रीटमेंट के लिए यूज कर रहा हूँ. व्हाट इज दिस डायग्नोस्टिक एमनियोसेंटेसिस? व्हेन आई यूज टू डायग्नोस एनी कंडीशन. फॉर एग्जांपल, इफ यू वांट टू डायग्नोस द न्यूरल ट्यूब डिफेक्ट्स, व्हाट you have to check, guys? You have to go for amniocentesis and check acetylcholinesterase in the enzyme. For example, if you want to check the fetal lung maturity, what is the 100% confirmation of the fetal lung maturity? So I will go for the amniotic fluid and check the presence of phosphatidylglycerol. If the presence of phosphatidylglycerol is in the amniotic fluid, that is a classical diagnosis. That's a classical sign of the fetal lung maturity. So for that, we'll go for the amniocentesis. Yes or no? To diagnose spina bifida and all. So these are all the causes of what? Diagnostic. These are all the procedures. These are all the reasons that we go for the diagnostic amniocentesis. So that can cause what? Oligohydramnios. But here we can go for therapeutic amniocentesis. That means we have to take the amniotic fluid out as a treatment in case of a polyhydramnios. So did you understand the differences between the polyhydramnios and oligohydramnios? I hope, guys, it's clear. Okay, now sometimes in a question, guys, they will write the liker color. Okay, contributor of this. If I write contributor of this amniotic fluid, अगर contributor की बात की जाए, guys, early pregnancy, it's maternal. Eternal. Then guys, fetal urine, from the fetal side, fetal urine is the contributor. Okay, lung secretions, skin and all that goes with the amniotic fluid. pH is neutral. Those things you don't have to remember, just remember this much. After that guys, if I talk about the second thing, talk about the second thing, from the color of the amniotic fluid, if the color is red, it goes with the antepartum hemorrhage, APH. If the color is green, that goes with the meconium aspiration, meconium aspiration. If the color of the amniotic fluid is yellow, yellow होगा तो RH incompatibility, golden yellow. Okay, if it's straw color, that is a normal amniotic fluid. Okay, if tobacco juice color, कितना लिखूंगा इस if tobacco juice color, tobacco juice, that goes with the intrauterine death. Okay, so the classical case guys, which of the following is not associated, which of the following is mostly likely to be associated, sorry, when it's AFI of 26, your answer goes to cleft palate. Your answer goes to cleft palate. So cleft palate causes polyhydramnios. Is it clear guys? Cleft palate causes polyhydramnios. Okay, renal agenesis causes oligohydramnios, and anisette causes oligohydramnios. Posterior urethral valve, you'll be leaking of urine as well in that condition, that goes with the polyhydramnios. So is it clear guys, everyone? All clear, everyone? This is more than enough for amniotic fluid dynamics. Write down in the comment section guys. Yes, most of you have studied these things, but yes, we are trying to cover every single topic in just 5 to 10 minutes mostly. Don't want to skip any single point that is important in the discussion guys, but I hope you all are recalling and tallying your notes as well. Chalo, good. Now, branches of anterior division of internal iliac artery. Branches of division of internal iliac artery include the accept. Okay, so you know guys, internal iliac artery we try to ligate in case of obstetrics. में याद रखोगे importance क्या है in PPH guys, we will ligate in case of postpartum hemorrhage. So importance is ligation in terms of postpartum hemorrhage. Okay, so write it down. They are ligated in postpartum hemorrhage. Okay, which branch? Anterior. Which branch? Anterior internal iliac artery. Anterior internal iliac artery. Okay, now my dear students, posterior internal iliac, remember, posterior internal iliac artery. If I talk about this posterior internal iliac artery, okay, if ligated, it will cause lower limb paralysis. Okay, ज़्यादा ही होगा, numbness. Okay, so how this question will come from the anatomical way. Okay, I have just mentioned here what I have just mentioned here, that anterior division of internal iliac arteries. Okay, so the classical case will be 35-year-old female is coming to you with the complaining of numbness in the lower legs. Okay, she's complaining of loss of sensation, tingling, numbness. Okay, loss of energy, kuch bhi bata do, in the lower left limb. Okay, lower leg. Then after that guys, patient is giving a history of bleeding after the delivery, for which patient was operated and ligated. Which of the following artery has a doctor misidentified? Okay, which of the artery has been ligated mistaken? Are you getting my point? So you have to remember which artery a doctor had ligated. That's why the patient is having the features of what? Numbness. Okay, so that means posterior iliac artery. But branch of this, you have to remember what are the branches. Okay, how do you remember guys? I remember with super gills. So You remember the branches are superior gluteal, branches are iliolumbar, and lateral sacral, so rather remembering the ovarian branch, okay, if you go to remembering the anterior branch of internal iliac artery, anterior iliac artery branch, 7 to 8 branch, so rather remembering those 7, you just remember these 3 guys. So in a question you will try to find these 3, okay, uterine, obturator and clitoral. Don't go to remember that, just remember these 3 for the posterior branch, and you don't have to ligate. Is it okay guys? So among the which of the following is not a branch of the anterior division of iliac artery, guys? Answer in the comment section. Just remember short gills. So short gills, the first one, superior gluteal, that is a branch of posterior internal iliac artery. Clinical anatomy question. ठीक है ना guys? Anterior branch and posterior branch, anterior branch and posterior branch. Is it clear? So I can show you the image as well. Okay, you can check the image as well. See guys, from the main notes mentioned as a picture, guys, you ligate the anterior branch of the internal iliac artery and don't ligate the posterior branch. Don't ligate the posterior branch. Is it clear guys? Because the patient will cause what? Numbness. Okay, and even if after the anterior internal iliac artery ligation, if the bleeding is not stopped, then you go with the supra cervical or subtotal hysterectomy. Okay, you only take the uterus out, you don't take the cervix, and then total abdominal hysterectomy, uterus plus cervix. So when all these surgical procedures are failed in terms of a postpartum hemorrhage treatment, you are definitive, and the last best treatment option will be hysterectomy. So the last option goes with the hysterectomy. Chalo. Okay, chalo guys. Now the next question. A 28-year-old gravida 3 para 1 abortion 1. Okay, 33 weeks of gestation, came to the obstetric gynecology clinic for a regular ANC. She's coming there for a regular ANC. She's a known case of preeclampsia. Okay, diagnosed at 26 weeks. She's a known case of preeclampsia, diagnosed at 26 weeks. Now her blood pressure is 130/90 and NST is reactive. Her non-stress test is reactive. What is the plan of management in this patient? So she was a known case of what? Preeclampsia. So I've already discussed guys preeclampsia kya hota hai. So let me discuss guys gestational hypertension. So in that particular topic I'll be covering each and everything. Very important topic guys, gestational hypertension. Okay, if I talk about gestational hypertension guys, remember it occurs more than 20 weeks onwards. Now if the patient is already hypertensive, I will call it as क्या बताऊंगा उसको बच्चों, I will call it as chronic hypertension. Okay, if the patient is already hypertensive, I will call it as chronic hypertension. Okay, but if it occurs more than 20 weeks onwards, how much should be the blood pressure, sir? It should be more than 140/90 on two occasions, 6 hours apart. This is a case of gestational hypertension. Okay, gestational hypertension. So more than 20 weeks, more than 140/90, 2 occasions, 6 hours apart, you call it as pregnancy induced hypertension or gestational hypertension. After that, my dear students, remember guys, what can be the pathology? Okay, what can be the pathophysiology? Sir, why this hypertension is occurring? For example, in GDM I told you, due to the human placental lactogen or estrogen it is occurring. But here guys, at 20 weeks, what is occurring? Sir, trophoblastic invasion is occurring. But during in gestational hypertension, there is no trophoblastic invasion. Okay, incomplete trophoblastic invasion. So what is this trophoblastic invasion? Okay, during this trophoblastic invasion guys, resistance, in short I will tell you, resistance in high artery vessels. Are you getting my points? Resistance in high artery vessels, that will be converted to the low resistance. Okay, resistance from high will be converted into the low. How? These smooth layers will be replaced, okay, under the trophoblastic invasion. When the smooth layer, okay, or when this spiral arterioles, it will be not replaced from high to low, what will happen to the resistance in these vessels? Sir, it remains high because trophoblastic invasion has not taken place. When there is an incomplete trophoblastic invasion, resistance is high, there is vasospasm, okay, and this vasospasm will cause what? Pregnancy induced hypertension, because vasospasm is there, resistance is there, hypertension is there. So what is responsible at 20 weeks onwards, guys? Incomplete trophoblastic invasion. What is this trophoblastic invasion? Resistance of high vessels is changed to low, but with the due to the conversion of what? High spiral arterioles to the low spiral arterioles. But when it's not happening, what is happening to the resistance, guys? High, it is not converting. Though that's what the pathophysiology is: incomplete trophoblastic invasion. Number one thing. Number second thing, guys, okay, it will cause vasospasm and pregnancy induced hypertension. Yes, the layer, वही ना, स्पाइरल आर्टरीज की लेयर नहीं चेंज हो रही है, so the resistance remains high. That's simply called as incomplete trophoblastic invasions. Now after that, what will be this a treatment? Now if this more than 140 by 90, if the blood pressure is more than 140 by 90, plus there is proteinuria. So what is proteinuria? So if there is a protein inside the urine, now how much it should be? It should be 300 mg. It should be 300 mg for 24 hours urine, okay, or it should be 1 urine dipsy positive, okay, dipstick. This is a classical case of preeclampsia. This will be the classical case of preeclampsia. And when I've already told you, due to this preeclampsia, when there is a decreased blood flow, okay, decreased blood flow हो जाएगा, तो ब्रेन की ओर cerebral hypoxia हो जाएगा, patient will have convulsions. So preeclampsia plus convulsions will be there. Preeclampsia plus convulsions will be there. The patient will have what? Patient will have eclampsia. सीजर होंगे साथ में, ओके, सीजर होंगे साथ में, तो पेशेंट को क्या बोलेंगे हम? पेशेंट इज हैविंग eclampsia. Is it clear, guys? Patient is having eclampsia. Now if I talk about the treatment for this, it's magnesium sulfate, okay, it is magnesium sulfate, okay. What will this magnesium sulfate do, guys? It will cause vasodilation, okay. So one, it will cause vasodilation, there will be more blood going to the brain, okay, so there will be no cerebral hypoxia, so there will be no guys seizures. Is it clear? So how magnesium sulfate is working, guys? Vasodilation कराएगा, ज़्यादा blood होगा. How this will cause vasodilation, guys? By entering the calcium into the vessels. Chalo. After that, guys, after that, this magnesium sulfate, remember that it's a treatment for, it's also used in treatment of, it's a neuroprotective, it's a tocolytic as well. So tocolytic drug as well. Question will be asked, which of the following drug is neuroprotective, used in eclampsia, and a tocolytic drug? So your answer goes to the magnesium sulfate. Then you have two regimes for magnesium sulfate, my dear students. Remember, magnesium level should be 4 to 7 milli equivalent. Utna dena hai. If it's more, it will cause toxicity. What is the antidote? What is the antidote of this? So the antidote is calcium gluconate. What is the antidote? Antidote is calcium gluconate. Antidote is calcium gluconate. Number one thing. Number second thing is, guys, more than 10, there will be sign and symptoms of toxicity, okay, but you have to maintain the level 4 to 7 milli equivalent. Question goes, what is the first sign of toxicity? First sign of toxicity. Again an MCQ. So there will be loss of deep tendon reflexes, or patellar reflexes, or there is sluggish knee jerks. There are sluggish knee jerks. Number one thing. After that, what you remember, guys, from this is further, yes, there is a Pritchard's regime and Zuspam regime. One will be IM plus IV, another will be intramuscular only. So that goes with the treatment of magnesium eclampsia. Is it okay, guys? So the first sign is loss of deep tendon and patellar reflexes, followed by that, guys, there will be decreased urine output, then the respiratory arrest. Is it clear? और क्या होगा उसके बाद? Decrease urine output, उसके बाद respiratory ठीक है, so that is the treatment of eclampsia, that is the treatment of eclampsia. ओके उसके बाद क्या रखोगे याद, ट्रीटमेंट ऑफ हाइपरटेंशन. अब ड्रग्स हाइपरटेंशन में क्या देंगे, विच इज दिस वन. चलो नाउ ट्रीटमेंट ऑफ हाइपरटेंशन मैं यहाँ पे लिखता हूँ, आई एम राइटिंग इट हियर गाइस. ट्रीटमेंट फॉर हाइपरटेंशन, antihypertensives in pregnancy. I'm writing it here, antihypertensive and pregnancy. Antihypertensive in pregnancy. So what are the drugs that we use? Number first one is labetalol. Okay, labetalol is the first line drug guys, which is an alpha plus beta blocker, which is an alpha plus beta blocker. Number second guys, we also use alpha methyl dopa. We also use alpha methyl dopa, which is a prodrug. Okay, we also use hydralazine. We also use hydralazine guys. Okay, it's the arterial dilator. Number 4 drug guys, nifedipine, calcium channel blocker, and we use alpha 1 blocker called as prazosin. Very good drug guys, prazosin. It's also used in benign prostate hyperplasia. It's also used in case of antidote for scorpion sting. These are all MCQs. Okay, these are all MCQs. Now my dear students, what do you remember? Yes, side effect is tremors and orthostatic hypertension. Chalo, I will not go to the pharmacological point, you just remember this much in obstetrics. Very good. Nifedipine, yes. In if asked orally first choice will be sir labetalol, second will be alpha methyl dopa. Remember this question guys, if labetalol is not in the option, you mark alpha methyl dopa. But if emergency, if hypertensive emergency, यहाँ पे लिख देता हूँ. Now hypertensive emergency. Sir, if there is a hypertensive emergency, what we will do? In hypertensive emergency, you will first give IV labetalol. Okay, you can give up to 20, you gonna start to 220 mg you can give. Okay, but the alternative to this IV labetalol is IV hydralazine. So what is the hydralazine? So in hypertensive emergency, first drug you will mark guys labetalol. पहला कौन mark करोगे? Labetalol. And second you will mark IV hydralazine. Second you're gonna mark IV hydralazine. Yes, prazosin for the scorpion sting. Okay, also used in BPH. Is it clear guys? Is this clear? It was all about gestational hypertension. Yes, there is also chronic hypertension associated with pheochromocytoma and renal artery stenosis. Yes, and delta hypertension, that the pregnancy, during the whole pregnancy the blood pressure is normal, but in the later stage 36 weeks onwards it keeps increasing. Such a condition is called as delta hypertension. Okay, yes, okay, all clear. Now tell me the answer of the question guys. Now I've already told you guys what is the treatment. Okay, now I've already told you that about this topic. Now we will answer in the comment section. Her blood pressure is 130/90, NST is reactive. What is the plan management of this patient? Preeclampsia diagnosed at 26 weeks. So write down the answer guys. Let me check your answers as well. Let me check the answers now. What will be the answers? What will be the answer guys? So the patient, what will be your management? Will you go for magnesium sulfate? Will you try to give steroids, dexamethasone, and induce the labor? Will you plan for immediate LCS, or you wait till the 37 weeks of termination? You wait till term. Your answer your answer goes to yes, faster guys. What will be the answer? Very good guys. Yes, all the people answer, guys. You are you're allowed to make mistakes. I'm here to correct your mistakes. Okay, I was making the same mistakes during my time, guys. So you are allowed to make mistakes, and my job is to correct you guys. So unless and until you will not answer, you will not mark mistakes. So how come I will correct those mistakes? So you are allowed to make mistakes, but not blunders. है ना? Mistakes you can make, but blunder नहीं करना है. Don't make blunders. What is the blunder, sir? In case you will mark LSCS. Why you are going for LSCS? That is a blunder. Other option that can be or cannot be, वहाँ पे चलेगा. चलो, like let me answer it now, guys. The answer is wait till 37 weeks of termination. The answer is wait till 37 weeks of termination. Now listen to me, guys. Now first of all, guys, why I will give magnesium sulfate? She was pre-eclamptic. Yes, you can think about more than 140/90 blood pressure with the proteinuria, but she was diagnosed at 26 weeks. But right now she's just coming for what? Antenatal checkup. Right now she's just coming. Sir, can't answer BC Anisul. Okay, I'm explaining. Okay, now right now she was pre-eclamptic, but she was pre-eclamptic at how many weeks? She was pre-eclamptic at 26 weeks. That means at 26 weeks her blood pressure was more than 140/90, and she was having proteinuria, protein in the urine. Okay, but right now she's just coming for what? Antenatal checkup. She's just coming for ANC. Right now her blood pressure is normal, 130/90. Is she pre-eclamptic or GTN right now? No, more than 140/90. It's not more than 140/90, it's just 130/90. Her NST is reactive. Okay, there are two accelerations present of 15 beats per minute over a period of 20 minutes. So that means NST is totally fine. Non-stress test, okay, used for surveillance of the baby. You just remember, guys, in an antepartum surveillance chapter, when I will discuss that topic, I will teach you exactly what is NST, what are the tools that we go for the surveillance. But right now I'm mentioning that her blood pressure is 130/90. Her NST is a reactive. So is there any indication of magnesium sulfate? No, there is no indication of magnesium sulfate. She's not having any convulsions, and even she's not pre-eclamptic right now, so that you can answer that we can use it for the prophylaxis. Is it clear, guys? Option A, not answer. Chalo, option A gaya. Now, my dear students, number second, there is no reason right now you will go for the induction of the labor. Non-stresses. Okay, there is no reason right now you will go for the induction of labor. Okay, what is induction of labor? When you start the labor prior to the contractions, but there are no contractions present, you start the what? You start the labor. Okay, no, right now there is no fetal distress, there's no complications, and she's just how many weeks, guys? She is just 33 weeks. Why I will try to give dexamethasone for the fetal lung majority and induce? Is there any emergency, guys? No, sir, everything is fine. She's right now having normal blood pressure and her baby is totally fine. Okay, if the question mentioned NST is non-reactive, that means there is a distress in the baby, no accelerations present. Are you getting my point? So NST is okay, baby is okay, mother is okay. No reason, guys, you will induce the mother. Okay, a patient is coming to you just for an antenatal checkup. A female is coming to you just for an antenatal checkup. Okay, for now, guys, you just remember accelerations are the present. That means non-stress test is reactive. That means baby is absolutely fine. This is a test that is used to check whether the baby is fine or not. Surveillance test, antepartum surveillance में करते हैं हम, guys. We check for the biophysical profile, which includes NST plus AFI. Okay, modified biophysical profile. We check these in these tests. We check fetal movements, fetal accelerations, amniotic fluid. Okay, fetal tone, fetal breathing. All these tests, they are for the baby, and I'm telling you that acceleration is fine. Baby is absolutely doing fine. That is NST is reactive. Don't make it complicated, है ना? इतना तो है नहीं. NST reactive means NST is okay. When I will teach antepartum surveillance chapter, I will tell you what are the tools that you have to go for the surveillance that helps you in the surveillance. Are you getting my point? But right now accelerations are present. Fetal is absolutely fine. Mother is fine. Fetus is fine. Why you will try to induce the labor for nowhere? She's just coming for an antenatal checkup. Number 3, can you go for LSCS? Sir, LSCS, there is only indication of LSCS when the baby would have been in the distress. So baby is not in the distress. Baby is absolutely fine because NST already told you she's fine. Are you getting my point? No complication. Okay, baby is absolutely fine, mother is absolutely fine. Are you getting my point? Mother is not having any history of bleeding or anything else, so no reason for LSCS. So absolutely everything is fine. You wait till the term pregnancy when the baby will be absolutely what, ripened, when the baby will be, sorry, when the baby will be absolutely grown perfectly with no complications. So that will be term pregnancy. You just wait till 37 weeks and go for that. So the best management here will be wait till the 37 weeks of termination. Wait till the 37 weeks of termination. Is it clear, guys? So she's just coming for antenatal checkup. Okay, that is the keyword. She's just coming for what? Antenatal checkup. There, so there, the question in the beginning already mentioned that there is no emergency. There is no emergency in the question. And see, I didn't mention, no, if there would have been eclampsia or any other comorbidity, so then the answer would have been to what? Wait, yeah, sorry, the answer would have been LSCS. So why dexamethasone? Dexamethasone is used at 33 weeks. Dexamethasone, fetal lungs are matured up till 32 weeks. So we give this dexamethasone and betamethasone. क्या देते हैं guys? We give betamethasone and dexamethasone. Okay, two steroids for what? Fetal lung maturity. Okay, for fetal lung maturity. Okay, what will this they do, guys? They will increase the surfactant. Surfactant की वजह से क्या होगा? Fetal lung mature हो जाएंगे. Now how much to give, guys? Betamethasone you give 2 doses, dexamethasone you give 4 doses. This you give 12 into 12, 24 mg. 12 mg. ये वाले देते हो 6 into 6 into 6 into 6, 6 mg, 6 mg, 6 mg. So all combined 24 mg. Okay, betamethasone and dexamethasone are given prophylactically whenever there is an emergency by 33 weeks, when the baby is in the distress and you have to deliver the baby at earlier preterm labor. So at that time you have to first consider the fetal lung maturity. And how do you check the fetal lung maturity? I've already told you, you go for what? Phosphatidylglycerol. क्या check करते हो, guys? Phosphatidylglycerol in amniotic fluid. Phosphatidylglycerol in amniotic fluid. You go and check that. That is the confirmatory of fetal lung maturity. And you give 2 drugs, betamethasone and dexamethasone. This will be the question asked. How much betamethasone, guys? 2 doses. है ना? 2 doses. How much? 12 mg, 12 mg. To total 24. How much dexamethasone in 4 doses? 6, 6, 6 and 6. Is it clear? 2D. Yes, yes, exactly. 2B, 4D. है ना? 2 doses of betamethasone, 4 doses of dexamethasone. Total will be 24. Is it clear, guys? Yes, also one more. Yes, 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 you all are right. Also one more way to check the fetal lung maturity. You go for lecithin and sphingomyelin ratio. Lecithin and sphingomyelin ratio. And remember that, guys, in GDM, the fetal lung maturity is delayed. That's why we have to give steroids, but make sure we have to only give steroids to the patient when she's admitted, because steroids increase the blood sugar levels. Steroids include the blood sugar levels. Is this much clear, guys? Write in the comment section, please. Is this much clear? Yes. Is this much clear? All of you who are live, who have joined, guys. All clear? So always focus on the question whenever it's mentioning that a mother is coming for the antenatal checkup or she's having emergency. Yes, sir, clear. Okay, so a quick recap, guys. We just solved like 1, 2, 3, 4, 5, 6, 7, like 8 topics. Yes, yes, LS ratio more than 2. Exactly. So guys, chalo. So a quick recap of this first chapter. I talked about postpartum hemorrhage. I talked about the causes. The question was, which of the following will be the second, which of the following will be the cause of a secondary postpartum hemorrhage, which is due to the retained placenta beds. It's due to the retained placenta beds. Okay. Then 40 stone, trauma, tissue and thrombin deficiency. I've discussed one by one what is stone, trauma, tissue and thrombin deficiency. Treatment, you will remember, guys. Treatment, you will mention a treatment I've already discussed. Okay, what is the treatment? You're starting with the oxytocin, then the methyl ergometrin, then the mesoprostol, carbopros, then we go for the balloon tamponades, Buckley's balloon, we use Foley's catheter, we use Sengistican tube and all, and eventually if bleeding is not stopped, we go to the surgical management and we end with the hysterectomy. Remember the artery of the ligation, guys. Uterine, ovarian and internal iliac. Which one you will not ligate? Posterior one. What are the branch? superior gluteal, iliolumbar, and lateral sacral. Is it okay? Contraindications of methyl ergometrin, you will remember. PIH, congenital heart disease, RH incompatibility, and the delivery of the second time. Before the delivery of the second time, you cannot go with that, because if you will give methyl ergometrin, bandi ho jayega dusra baby, you will not able to come out. So you only give it when there is a delivery of the second time. Chalo. Then PCOD, I've already discussed. The another name is Stephen Leventhal syndrome. Rotterdam criteria, 3 things you will check: anovulation, hyperandrogenism, and the plus minus look on the UHA. It will give a pearl of string appearance, necklace wala appearance. And this, don't confuse this image with the ovarian hyperstimulation syndrome seen in the IVF patient when the FSH is given. Are you getting my point, guys? Chalo. After that, the treatment for the hirsutism, this is due to the hyperandrogenism. You give the anti-androgens, you give spironolactone, finasteride, cyproterone acetate, OCPs as well. OCPs as well are used for the hirsutism treatment. Then the surgical treatment will be ovarian drilling, guys. Why? Because there is a thick stroma. The follicles are not getting the glucose, guys. So less energy is there. So eventually they are not growing. So when you go for this ovarian drilling, it will decrease the thickness and they will get enough glucose. After that, guys, also seen acanthosis nigricans over there. It's seen in diabetic mellitus as well, IBDs, obesity, सब में दिखता है. But I have mentioned one clear-cut point that which cancer will be associated in the paraneoplastic syndrome. It's gastric cancer and small cell cancer. Yes, small cell SAS. So smoking is associated, because of smoking, oat cell cancer occurs. There are 4 cancers of lung you will study in your paths, but so far just remember acanthosis, gastric cancer or oat cell ke saath hai. Then, guys, endometriosis is due to the retrograde menstruation, due to the backflow of menses. And the most common site will be ovary, followed by the pouch of Douglas. The investigation of choice will be laparoscopy, and the laparoscopy we have a classical findings of powdered burn lesions. Number 1 thing. Number 2nd thing, there will be the old blood accumulated in the cyst called as chocolate cyst, and there will be the uterosacral ligament nodularity. After that, guys, the treatment in there will be the atrophy of the endometrium with the help of a progesterone, depot medroxyprogesterone acetate. बच्चों ये भी याद रखना, this depot DMP, how much to use? 150 mg every 3 months. 150 mg every 3 months. Okay, this is used as contraception as well. In which contraception? Antara is a contraception. Inside antara, what is this? Injection DMP is, you have to use this 3 months, every 3 months, but it has a side effect of irregular cycles. Again, a question asked. Then anti-estrogen you will use, because the proliferation of the endometrium is due to this estrogen. So you will use anti-estrogen drug, which is a danazol. Danazol will the faster atrophy, but the side effect you will remember as a virilization, that is breast atrophy, clitomegaly, and hoarseness of voice. After that, guys, classical age of 25 to 35, complaining of dysmenorrhea, dyspareunia, dyschezia, dysuria, is endometriosis. After that, guys, carboprost, active management of third. Yes, active management of third stage of labor I've discussed, guys. What are the 4 steps? You administer the uterotonic agent, delayed cord clamping, delivery of the placenta, and assessment or the observation. Okay, so remember that, guys. Preeclampsia causes, for how preeclampsia predisposed to the oligohydramnios and eclampsia convulsions. Okay, decreased blood flow to the brain, decreased GFR, decreased fetal urine, decreased amniotic fluid, oligohydramnios, decreased blood flow to the brain. There is a cerebral hypoxia causing the convulsions. Followed by that, guys, I've discussed GDM. The baby will be hypoglycemic. That is the question. Why? Because there is a hyperplasia of beta cells of pancreas. A baby will be polycythemic, and there is increased growth hormone factors. The baby, the hyperglucose will be changed into the fat. That's why the baby is macrosomic. The complication is a shoulder dystocia. You'd go for the 1-step test, 75 mg. If fasting should be what? Less than 92. After 1 hour, it should be less than 180. After 2 hours, it should be 150. Any one of the one will be the confirmatory of what? Will be the confirmatory of GDM. Is it okay? Macrobert's maneuver is used. If patient is already diabetic, that goes with the overt diabetes. Most common neural tube defect will be sacral agenesis. Most common heart defect will be transposition of great arteries. Okay. First management in case of a PPH or any bleeding in case of a pregnancy, you always try to resuscitate the patient. Trauma में कर लोगे ABCD है ना, airway, breathing, circulation, but यहाँ पे bleeding हो रही है ज़्यादा, patient will go into the shock. Always try to secure the IV lines to prevent the shock. IV 14 gauge cannulas. Are you getting my point? Then polyhydramnios, oligohydramnios, guys, we discuss AFI less than 5 centimeters and AFI more than 25 centimeters. The reason most common here will be bilateral renal agenesis, because anything wrong with the kidneys will decrease the fetal urine, eventually will cause oligohydramnios. Or the drugs that will inhibit what? The urine output, decrease the urine output will cause oligohydramnios. And intrauterine growth restriction or a diagnostic amniocentesis or the post-term pregnancy will have oligohydramnios. Followed by that, polyhydramnios will be associated with a twin pregnancy, duodenal atresia, esophageal atresia, cleft lip, and all these things. Is it okay, guys? The treatment here will be ACE inhibitors to decrease the urine output. You will further decrease the oligo, which will further cause oligohydramnios, or you can take out the bleeding, you can take out the amniotic fluid by doing therapeutic amniocentesis. When you use the amniocentesis for the treatment, the branch of the posterior ones, super gills, guys, superior gluteal, iliolumbar, and lateral sacral, already discussed. Then last one, guys, gestational hypertension, guys, we have discussed that what are the drugs. First of all, labetalol, alpha methyl dopa hydrolazine, nifedipine, and prazosin. That's why, guys, in PIH, why furosemide like diuretics are contraindicated, because already there is a vasospasm due to the incomplete trophoblastic invasion, and if the patient, you will give more these drugs, what will happen, sir? It will cause more vasospasm, so patient ka blood pressure zyada बढ़ जाएगा. So keep that thing into the consideration, guys, why these drugs are contraindicated. And what was the reason of the pathophysiology we have discussed, sir? It is due to the incomplete trophoblastic invasion, vasospasm, है ना, because the resistance of the vessels is only high, because it's not replaced by the less vessels. Are you getting my point? Then, guys, preeclampsia, if more than 140/90 proteinuria is associated, that is preeclampsia. And if a preeclampsia plus convulsions are there, that goes with the GCTS. Okay, that goes with the eclampsia. You manage with the magnesium sulfate, guys, 4 to 7 milliequivalents. Antidote is calcium gluconate. Okay, more than 10 is the toxicity sign and symptoms. First symptom will be loss of deep tendon reflexes. Second will be patellar first symptom will be loss of deep tendon reflexes. In options, he can mention decreased patellar reflex, mark that. If he mentions sluggish knee jerks, mark that. Second will go to the urine output. Is it okay, guys? So the question was, she was just coming for the antenatal checkup. She's absolutely fine. Your answer goes to the wait till 37 weeks of termination. And in hypertensive emergencies, guys, IV labetalol is the first choice, followed by IV hydrolazine. So this is all about our discussion, guys. I will come with the part 2 as well. We have a lot to discuss. We just discussed obstetric few topics. I hope this discussion will be useful enough to you all. And I have tried to cover almost 80% of the important stuff here, because as a discussion, it's not a main class. We can go with every single bit. But surely, guys, if you revise your notes and you go to this discussion, that's surely going to be helpful. 100% going to be helpful. Okay. If you have any doubts related to this session, guys, you can ping me on the Telegram. But only doubts related to the study should be there. Okay, no other text. You guys can ping me in the Telegram, Dr. Talib Bilal, so I'll be answering your doubts for sure. Okay, so I hope, guys, session was good enough and you all are prepared for the exams on 6th July. Okay, so if you have anything to, guys, write, you guys can comment it down. I will come with the part 2 very soon. Okay, according to my schedule, I will try to make myself available, so I'll come with the part 2. Yes. Okay. So yes, you can solve the daily MCQs on my channel as well, FMG with Dr. Talib Bilal. You can solve the questions here. Okay. Every day 8 p.m. questions will be uploaded there, guys. To increase your preparation and boost your preparation, you can solve the questions as well. And in case any doubts, always there. Bahut dhanyavad. Best session. Thank you. Thank you for your guys' comments. I am glad that sessions was good enough and you enjoyed. Okay. Chalo, guys. Okay, I must leave now, guys. Keep studying. Okay, don't compare your knowledge with anyone. You keep studying, give your best shot. Okay, listen to the revisions, solve the MCQs, run your own race, and you surely gonna make it, guys. Not a big deal, guys, but increase your speed of solving questions, because 50 questions, 50 minutes, then section A, B, C, new rules. So I hope you clearly make it. Good luck to everyone. Good wishes to everyone. Okay, guys. Chalo, guys. Goodbye.